We're going to get into some really good talks around quality today and what that actually means. A lot of people say, we're trying to deliver quality healthcare for low cost in order to achieve better outcomes, but it's not always clear what people actually mean by that. So we're going to get into that today, starting with a fantastic talk from Scott Thompson. The attendance sheet is live, by the way, so sign in so we can make sure that we know that you're here, whether you're a formally registered student or not. I see a lot of repeat names, so y'all should understand the gist by now, but if you have questions, by all means, drop them in the chat. I see a hand raised. Melissa, did you have a question before we get going?
Sorry, I don't know how to turn it off.
That's okay, I'll lower it for you. Okay, so then let's get into it. Reese?
All right, so today I have the pleasure of introducing Scott Thompson. He is the Prime QIP project manager for UCI Health, managing Medicaid waiver performance programs from DHCS and CMS for the health system. Prior to joining UC Irvine Health, he held CIO, COO, and VP development roles in managed services organization, a Medicare Advantage health plan in Puerto Rico, and several software development companies delivering EMR, clinical trial management, and case management applications. His clinical background includes associate nursing faculty and CCRN in a combined trauma critical care unit. Welcome.
Thank you. Everyone can hear me okay, and you should be seeing an intro slide for Advanced Health Policy Elective. So is everyone looking okay on that?
Yep,
we're good to go.
Good, all righty. Wanted to bring up first why the bio and why talking about this is that when you look at quality and value, especially around the quality metric programs we're going to be talking about, it's the job I do every day. I've been here about 3.5, almost 4 years now at UC Irvine. But it touches on really 3 main pillars of discussion when you're working with this. There's the clinical component of looking at quality. There's the IT or reporting kind of component. So you talk a lot about data, and there's kind of a leadership component as well. And so one of the things that is, if you work in these areas, or if you find that your clinical practice, you're getting involved in these areas, it's good to remember that there's always kind of this triad going on together. In terms of UCI, a lot of you know this about our hospital, but we're fairly large, 400 acute beds, and this is some, this changes because now we've got a big tent out front and people are, we got all this varies day to day, but we have a lot of things moving here. And when we talk about quality in this organization, it's a complex process, and there's a lot of moving parts to it because we do a lot here. It's sometimes easy to think of it just as the area you see in front of you, especially if you're in an outside clinic or just in the hospital, but there's a lot of moving parts to our organization. Okay, and there's contact stuff if you ever need to find me. Okay, so starting into this, when we talk about quality metric programs and quality and value in the clinical areas that we work in, it's important to think of it not just as a single thing. It's not one patient with diabetes who might have an A1C of a certain value, although that's part of it. That's something, a discrete point you measure. When we look at quality and value and these metric programs for all sorts of different programs that we work in, we really look at it as the capacity that we have to achieve good results. And then what are the rates that we do in that capacity to be able to achieve it? So we look at things like, how many patients do we have in the group? In that group, how well are we treating them according to a measure? It's really important not to get too hung up in the rates or in the specs themselves, because specifications always seem to trail behind clinical ones. So I always bring up this idea, we have medical or clinical goals that we want to do, and then the non-medical goals, which is usually financial achievement or participation in programs. And so you'll find us constantly bouncing back and forth between the two. There's what to do for a particular patient and what do we do to achieve a certain rate or goal in quality programs. So there are a lot of quality programs out there. And you've probably heard of some of them. There's very few people who've heard of all of them because this is just a starting point. But there are federal programs that come out from CMS, the Centers for Medicaid, and those are the guys in Washington that manage all the federal dollars. And CMS has things like HEDIS and ECQMs, which are electronic clinical quality measures. MIPS and MACRA are ways of measuring providers and what they're doing. And then we've got specialty places like the FQHC, which is a federally qualified health center, where they get special funding in dollars, but they've got their own quality programs called UDS, Uniform Data Services, I think it is. So you can think of this big sphere of federal quality programs. And then largely as a result, or certainly camping onto the result of the Affordable Care Act, way back when that started, they expanded Medicaid. Now, Medicaid, again, just making sure everyone's level set, so I apologize if you know this, but Medicaid are state programs. And this is people that are in a state that may have financial constraints or might have certain qualifying characteristics in terms of, they're young, without parents, they're foster children. A number of things can get you into a Medicaid program. In California, we call it Medi-Cal because it was cute and it has to do with California. So we call it Medi-Cal here, but it's just a Medicaid state program. But that's where we have a number of programs called, one was Prime that's just ending now, and a new one, which Prime, all these things stand for something. Prime was a reorganization of the hospitals. QIP is one called Quality Incentive Program. WPC is Whole Person Care. But these are all acronyms for programs, and each one establishes a certain amount of funds or qualifying, and it's all ways to kind of manage and measure how we do, how we basically perform for the state. There are organizational ones that are out there too. NCQA is a huge standards organization, and they have standards around ambulatory and inpatient ones that you have to qualify for to get NCQA certification. CMQCC is a state organization around maternal child care. And we also have commercial quality programs coming in, one of which is federal, which is Accountable Care Organizations. HealthNet is a commercial one. They have a pay for performance quality one as well. So there are dozens and dozens of these different programs that just hit UCI alone. And if you can imagine, this is spread out this way all across the nation, different federal, state, and local programs all impacting care. So when you get into clinical practice, I can guarantee in one point, you're going to be involved in this. Either I'm just doing my job and taking care of patients. They're going to be talking to you about making sure we have, good standards of care. We apply it consistently. Are we hitting the marks? You may move up into leadership, where you're having to deal with groups or peers or potentially people you manage to try and hit the goals of these. So we're going to be, I'll stop here for a second. I've kind of been rolling through a bunch of kind of prep data here. Are there any questions? Let me see, I'm going to watch the chat also.
Yeah, and Reese and I have our eyes on the chat box too, and our participants know that if they have questions as we move through your slides, to just drop them, and we'll just interrupt you as they come in.
Okay, I do encourage questions. It's fine if you see something you don't understand, or you'd like me to elaborate, or you'd like me to shut up and move on. I'm good for all those. So just let me know. This is really about what you're learning here too. So very open to that. All right, so this is something I deal with every day. So I tried to break it down into some structural things to give you a framework to put it in. When we talk about a quality program and quality and value in clinical care, it kind of boils down to three major flavors. And one is that we might do something where we look at our care, we take data out of the Epic system that we use here, and we'll report it. But we just get paid sometimes just for reporting data. We send it in, they say, thank you very much. Yes, that seems good. And then we get money, and that's called pay for reporting. And it's one of the easiest ones because they just take whatever data we send and we get, achievement success. Now there's a whole other type, which is called pay for performance. And this gets really complicated because how do you manage performance? How do you even measure, much less manage performance in a clinical setting? And so pay for performance programs are really moving into the majority of cases when money's involved, because they like to have something where you're moving towards a goal. And there's, we'll talk later on about how you manage those goals, and we'll go into the details of how to calculate it. But it's always good to keep clear which program is which. And then the third type is what's called a qualifying performance. And this is where they'll put out a standard, like we want you at 49%, whatever the measure is. We want you at 49%, or we're going to kick you out of this program. An example of that would be like our federally qualified health center here. We have a couple major locations. It treats a lot of patients in them. They are significantly busy, but we have to show every year that we meet qualifying thresholds of performance, or they take away our license and we have to shut the doors. And so that one doesn't have any direct financial achievement. No extra money comes in, but if you don't do it, you get thrown out. The other one would be an accountable care organization. We'll often have to send in data. And again, if you fall too low in your performance, they will kick you out of the program. So this is the first poll. So we're going to try this out. Just wanted to get your ideas, and this hopefully will be, see how people do on this. But when we look at the idea of quality and value programs, this idea of measuring clinical practice and putting rates and targets on them, what do you think? Is it a waste of resources? Is it exemplary, standards of care? Is it just a way to move money around, or do you think it's a way to track our workloads and performance? What do people think is the most correct answer?
So the poll is up for everyone to fill out. I have seen, it looks like 2 people have filled it out. I'm also sharing my screen, so we'll be able to look at the results at the same time. In order to toggle between our screens, everyone, you can go to the top of Zoom, and it should provide you with 2 options in terms of like whose screen to look at. So it looks like we have 8 people, and I'll go ahead and show the results. So we have about 50% who say it provides exemplary standards of care to follow. It looks like we got a couple of people that said just a way to track our workloads and performance. And then we have another person who said a way to allocate funding that gets around favoritism and political maneuvering.
Very good. So we kind of have a not a clear winner. A lot of these have different, kind of facets to them, and you're all right. And there's variations of all of this in quality programs. So there's no one right answer here. When you look at quality programs, they target topics that are good. I haven't seen a quality program yet that doesn't have solid patient care at heart, what they're trying to measure, which does it provide exemplary standards of care? It's probably not exemplary, but they do provide some degree of standard that, we'd like all hemoglobin A1Cs under 8 or 9 for different patients. We'd like blood pressures under 140/90. These are good goals. They're good, solid clinical goals. But remember, metrics in general, usually the specifications that we use may fall years or even 5 years, 8 years behind clinical practice. And the way medicine evolves nowadays, you can get standards that are, significantly out of touch. I just left a conversation discussing whether microalbumin testing was better for people with kidney disease rather than the, looking at regular protein levels in their urine. These details, the details are what get you in terms of, is it good clinically as a standard, or is it something just to kind of measure it in general? But the other things too, it does allocate funding. It's how we allocate a significant amount of the Medicaid expansion funding that comes from the federal government is allocated through this QIP program, because they can see and measure and make sure that it's being used appropriately. So it does get around just arbitrarily passing out the money. Epic, when you work in an EMR system, I have a bit of responsibility. I've built 3 different EMR systems over my professional life. EMR systems try to help providers and caregivers do their jobs, but it has a lot of different goals, including billing and tracking and regulatory compliance and quality. And some of those things do work to get in your way as clinicians when you're one-on-one with a patient, and how you spend that 17.5 minutes in that patient encounter. It's a real balance between time you spend on the EMR and time you spend talking to the patient. And it's one way we can track our work. So these can all be correct. So we're going to drop into a little more of the meat of actually how do we do quality reporting and how do quality programs work. And this is meant to give you some kind of appreciation for what maybe say people like me do, but also how your clinical work is totaled up and how it's presented. So a couple of terms, we use the word measure a lot, and we throw it around, and it's kind of an overused term, but what I like to use it as is when you look at a quality measure, like what is their hemoglobin A1C, does this patient, did they get a mammogram? That is a singular data point for a patient. And it exists within a population of patients that we define. Some of those patients will be diabetic, so they might get into the denominator that I'm going to calculate, because it all comes down to very simple fractions. They might have successfully gotten their A1C down below 9%. Okay, so now they're in the numerator. But they also may be on hospice. So because they're on hospice, we're not going to worry about this quality of life thing. So they might get excluded from the measure, even though they qualified for everything else. So right off the bat, you can see that it's not simple. You start with a wider range of patients and you start defining groups, and those definitions are extremely extremely detailed and laborious and fun to go through. The QIP program has actually gotten smaller. It's only about 450 pages of specifications. The earlier Prime program that we did up until last year had over 1,000 pages of documentation defining how to do these kinds of numbers for 50 some odd metrics. So 50 metrics, 1,000 pages, you can kind of get the idea. There's a lot of writing involved in this to try and nail it down. But what's really, to me, we look at patients individually, but then when we get to quality itself, in order to improve it, we need to look at quality in a sense of a rate. When we look at all of our patients, you take your panel of patients and you've got 20 diabetics that you're treating, you want to look at, well, the 20 that I have today may not be the 20 that I have next month, because some patients may leave, other patients may arrive. But for a quality program that looks at my performance over the entire year, what's important is how am I treating them as a group? And so I deal a lot in communicating with different clinics and locations to say, what's your rate over time? Are you, in general, as you treat this population, as some come and some go, are you keeping the general level of quality high enough? And so we look at a rate or a percentage rate of achievement, and that helps turn individual patient encounters into kind of a measurable number that we can deal with. I can compare the rate this month to the rate last month or the rate last year to see if we're improving or if we're declining in what we're doing. When you look at that and you say, well, 15 out of 20 patients is where I normally sit, you can kind of get an idea that your capacity is, I'm running about 20 patients. So I've got to basically right size my staffing, my systems that I'm using, what kind of equipment do I have to be able to manage that size of population. Some are really small. You may have just a handful of patients. Others, when we look at things like how do we do on screening measures, like screening for depression, screening for smoking, looking at the use of drugs and alcohol, those groups can be in the tens of thousands. And for smoking, like right now, making sure we do a smoking assessment and treat them if they are a smoker, to get them some kind of counseling. We're at like 98, 99%, but that's where the national averages are. So we have to work really hard to be virtually perfect in making sure everyone's screened in order to stay up at the national levels for it. So when we look at a quality program, you get this idea it's measuring individual events that you do with patients and combining those into a rate. And then it's what does the program do with that you're going to be working in. So when you're in clinical practice, they may come to you and say, oh, there's the XYZ program that we want to do really well in. Probably the first question I would have is, what is this program about and how does it relate to a standard of care? I find it much better to look at, rather than looking just at trying to meet a financial goal, I like trying to meet clinical goals and then let that translate into financial success. So we just get really good at doing what we do clinically and making sure we meet our standards. And if our standards are high enough, we'll do fine in the quality programs. But if you're getting involved in a particular one, you want to kind of see, is this a financial one? Is this a qualifying program? Are we looking at certain outcomes where, yes, we might be able to make, we might be able to make $10, but if I have to invest $200 to make 10, it may not be a path we want to go down. So sometimes you have to choose not to participate in certain quality things because for our specific population, we just don't have enough of those patients. The financial return on it's not enough. Others might be, we just want to look, at how we want to do this because we want to see how we compare to other university settings or other different types of hospitals where UCI here is a public hospital, but there are also district hospitals or private hospitals that we can compare ourselves against to see how we do against them. Really to identify gaps where if somebody's outperforming us, we want to go find out why. And so then we can improve our results as well, because in general, as I've worked with all the clinical locations here, everyone really wants to be the best. And I would say in general, we meet that. In the last round of Prime and QIP programs, we were getting up to 30 or 40% of our metrics were above the top 10 percentile in the nation for things. One happens to be smoking screening, but also some of our diabetic management. So we're at the top 10% in the nation, and we're maintaining that year over year over year. That's showing you the kind of standards that we have here are extremely high. I'm gonna pause for a second. Everyone tracking it? Is this all? Any questions or anything?
Seems to be registering. No questions yet.
Okay, well, good. All right. So when we look at some of these quality programs, and as a clinician, when they come to you and start talking about, we're going to measure these things, or you want to start translating it into practice, it really helps to break them down. There's three major types of quality metrics that we run into. There's, did you have the intent to do it? Did you have an actual action that you took? And if you took action, is there a result? And we can measure all three of these, and there are measures for all of them. So one of these might be, if I, let's take a diabetic one. Diabetic's a good one, because we can have measures that say, have you identified diabetics with, hemoglobin A1Cs above or below a certain value? Now that takes it all the way through to the result. Realize that if I had the intent to do something, I've identified that they're diabetic, and my action is, have I ordered, the intent is to measure them. So did I get a lab ordered? Yes. So the intent is, I want to do something about it. First step is, I've got to get a lab ordered. That's intent. We order it. Getting a lab's pretty easy. Now the action is, I probably need to prescribe something. I've got to do something, which is to set an order, to give them a prescription, to send them to some kind of nutritional program, to do different, kind of teaching and counseling ones to get them to understand their disease process. So that's an action we're taking that's impacting the patient. Patient may have to do part of that. But then there's the idea of measuring the result. Now the result is often termed compliance. Is the patient compliant, doing what we're saying? Are they? But in general, the result is something we measure. So like, is their A1C actually below 8%? If it is, then we've achieved the result, but it took the intention, ordering the lab, intervening with different actions, the patient having to do all those actions, and then actually seeing the result as well. I can order all of the insulin for a patient that I want, or oral meds or anything else, but if they don't take them, if they don't do the nutritional stuff, if they don't exercise, we won't see the result in the A1C. And so we're seeing quality metrics, one, get more difficult, like the diabetic one, which only rewards us for results where their A1C is below a target level. There are many others where they will reward us if we just get the lab. So patients who are on certain persistent medications like diuretics, we want to make sure that every year, at least once a year, we get a potassium and creatinine lab for them. That measure only measures the action. If we get the lab result, we meet the measure. It doesn't matter if it's good or bad. The result is irrelevant. We still achieve the quality metric by just getting the lab ordered. And so you can kind of see things that some quality metrics can be quite hard to obtain because it deals in the results. In general, intent is pretty straightforward. Do it when they're right in front of you. Actions, a little more complicated. You got to get them to pick up things or go someplace. Results are the hardest of all. Getting blood pressure below 140/90 is difficult. And that's where we're seeing quality metrics go more and more, is towards results. So got a little thought process for you now, just to kind of set up the idea of how to look at quality programs. So you're given this task that someone in Washington just gave us $20 million to invest to address COVID. And we've got to decide, well, they say, put together a quality measure and outline how you would do that as part of this $20 million. Now, when they say impact, you've got to decide a lot of things. They're just saying generally 20 million for the COVID-19 impact. Now think about all the things that are going on with COVID. What kind of measure would you build, document and design to put out there? So I'm going to give you about 15, 20 seconds. Just think to yourself, maybe write yourself some notes about what you think would be an interesting measure. We're not going to have everyone submit it or anything, but go ahead and take that. And really do try to write something down. And think of someone who had to then perform and do this in clinical practice in different settings, maybe public hospitals, community hospitals, private clinics, with different patient populations, people who are employed, people who are on Medi-Cal, people who are over 65, people who are under 18, what if they're 5, different age ranges. And what I'm hoping is you're seeing that it starts really easily and then gets really difficult to do. Let's talk a little bit about some of the things that come up in a quality metric. So my first question is, did you take all 20 million? And if so, did you do it like all for testing? And then what about vaccination? Did you leave money for vaccination if you were doing testing or vice versa? Is what you were thinking of, did it target something specific and measurable, or some kind of action or some kind of result that could be really accurately defined? Can it be documented or recorded in the EMR? Are you going to have people write things down and submit it separately? When you look at your measure, who's going to have to do this? Is it the patient doing something? Is it the provider? Is it the staff that's in their office? Is a health plan that might ensure these people get involved in answering the questions? Because vaccination is all those things. Testing is all those things. Is it going to be something done at the point of care when we see them face to face? Or is it something you can do when they're not? Maybe it's a telehealth visit. And then really, let's say out of the 20 million, you took $1 million. That sounds like a lot of money, but we've got, what's it now? 30 million people in California now. So if I take $1 million and divide it by 30 million, it's not a lot per patient. And so is there enough incentive in how much of that funding you used to warrant people getting interested in it? And most of all, was there actual patient impact to what you thought you would do? Going through these, you can see that it's not a simple process, and it's easy to get diverted thinking that your thing is the most important, but then there's many other things out there to do that are equally as important as COVID. We should be watching flu. We should be watching all the other childhood diseases. Immunizations are down, and there's a lot of things going on that where quality programs can be used to focus on clinical care. So let's try another poll. Now, just based on what you just did, what do you think writing an effective metric for the people who do this, what do you think this is? So let's do a quick poll on that. Easy, brainless, it's simple, it's hard, it's insane.
So it looks like we've started to get some responses.
Okay.
Sharing my screen, showing the results. So it seems like it's harder or insane.
Yeah. Yes. Yes, and this is where you're absolutely right. It's hard. It winds up being something that let me bring up here. If I can get my computer to work. Sorry. Come on. This is where Zoom overloads my computer, so it'll be up here in a second. Oh, I just lost it. Okay. I will shortly try to show you an actual document from this, but writing these are hard, and almost every metric has what's called a steward behind them, which is a group that does nothing but work on that one particular measure. And I often talk with the stewards of one, like the diabetic one, or we're about to do one for HIV viral load suppression. Also, this one that we were talking about with diabetic patients, making sure they get a series of labs to check out their kidney function each year. We talk to these stewards who do nothing but think about that one measure. So if you can imagine, here's a group of physicians working at a national level to look at one specific measured thing so that they can write a measure that can be calculated fairly and accurately across the country for it. Let's see if my computer's acting a little slow here. Let's see. Here it is. So when you're done with that process, you wind up with something like this. This is a table of contents for one particular, happens to be for the QIP, the current California QIP program. But you can see here for controlling high blood pressure, which seems to be a very simple thing. They're talking about these are the changes they made this year. Here's what they're talking about, the different eligible populations, the age ranges, anchor dates for when they might have an outpatient visit or a telephone visit or an e-visit, different exclusions for different age groups, different value sets, which means listing of like, they have to have either one of these diagnosis codes or one of these procedure codes. And this all falls into what a specification for making sure that their blood pressure is below 140/90. All of this wording is designed to tell us how to calculate it and how to submit the data. And we're still in blood pressure. You notice I'm going page after page after page, all the way down to here. And that's just the sample to look at blood pressures. Things they think about are, should you take a blood pressure on a day when they had an invasive procedure? So if you're coming in for a colonoscopy, that's probably not the day I want to take your blood pressure to see if I'm keeping it under 140/90, because they're stressed out. And so they actually give us exclusions that say if they're having an invasive procedure, we don't count that blood pressure towards, are they low enough? So these are the things that the stewards think of for it. Okay, so let's take some examples and we'll do some math, and it will be simple math. It's just complicated in the number of numbers. All right, this is a case of comprehensive diabetic care. This is an eye exam. We want patients who are diabetics to get an eye exam, looking for problems in the vessels in the back of their eye once a year. And the achievement, this is a qualifying metric. So we have to be at the 25th percentile for the nation. And it turns out there's groups that look at this kind of stuff and they say, well, can't highlight, but I'll tell you, it's 52 to 76% of the national benchmarks. So nationally, the lowest 25% get to fit half their patients, and the top 90% in the nation get to 3/4 of their patients. Nobody's perfect. Now we calculate ours. We've got about 1,200 patients. We're getting 300. We've got 373 of them. The idea of a current rolling 12-month means from today, looking back 12 months, a year's worth of data, we are at 28.83%. We're not doing very well. We are below the 25th percentile in that. So they have this idea of a care gap. What is the gap between our current rate and the national benchmark rate? So clearly we're not getting there. So at this point, we are not getting program achievement, which means we could be kicked out of the program. So the care gap is the difference between the national rate we're targeting, 52, and our rate of 28. So we're 23% away. And that means out of our patient population, we need 675 patients. That's 52% of the 1,294 that are in the denominator. So that means I've got to go find 675 diabetics and get them an eye exam, make sure we have a documented eye exam on file. So I did that math wrong. See, even this gets complicated. Achievement should be 675. My apologies. We already have 373. So subtracting those two, we get 302 patients. So much, much easier, right? Got to go find 300 patients to get eye exams on to bring our performance rate up to the 25th percentile and qualify for the program. This is math that pretty much every qualifying or a lot of the quality metric programs use all the time. It's just simple percentages and fractions, that we track. So that's how you do a qualifying metric. So let's take another example. Let's look at the other style of it. But first, we're going to give some, just make sure we understand the terms, which is when we're moving now into like a pay for performance one. In a pay for performance program, we're going to have annual targets. So my target this year might have been 52%. That in a pay for performance, they want you to improve over the prior year. So last year's termed our baseline. That's the number we're starting with. And so we use the baseline, we calculate how much we want to improve, and that gives us our target. We calculate that using national or some kind of benchmarks. Typically, they're national ones, which define in terms of the 25th or 90th percentile. How does the nation do? How do we stack up against the nation? And then the care gap is the difference between our current performance and the target we set. So, and that can either be a percentage, or I can do it in terms of the number of patients we need to change. So using that, remember I said that this, when you look at how quality is done, it seems simple, but there's a lot of math involved in it. It's simple math, but it's still math, right? So deciphering all this, the achievement wants this idea of 10% gap closure. That means that every single year, we have to move our performance 10% closer to the 90th percentile in the nation. That's a forcing program that says you will over time get very, very close to and even exceed the 90th percentile, because that's how you remain successful. This is a very common way they word things. It might be 5%, it might be 20, there's different percentages, but the overall idea is year over year gap closure to a national target. So in this case, we're looking at, this is the infamous hemoglobin A1C we've been talking about. This is setting the goal of the metric is to get everybody below 9%. And even that changes from, some people will go for 9, some go for 8. Currently, our target is 9% here. We have the national benchmark. Basically, this is what's called an inverse metric. So sometimes measures can go not trying to get you higher, but can actually trying to get you lower. We want more people less than 9%, so they count it in reverse, how many are not. And so you can see the benchmarks go from 46 to 28%. Well, looking at our numbers right now, we're at 31.9%, means we're kind of in the middle benchmark range. So there is a small gap between us and the 90th percentile. And you can see there it's calculating 3.91%. The 10% closure is 1/10 of that, which is 0.39. So 10% of the gap. And so we wind up, because it's an inverse measure, you have to do a subtraction rather than an add. We wind up that our target is 31.5%. Now we have our target. Once we have that target, we can then go back to what's our current rate. We're at 34%. We've got a difference of 3%, or about 40 patients. So in this way, we look at measures, and we talked about the idea of a capacity or rate that we do. Those bottom 3 bullets, once we have your targets for the year, you set your target, and now you just constantly watch, well, how many do we have today? How many do we have today? And each time you get a patient where their last A1C is below 9, it changes the numbers, and we're able to track our progress towards that goal for it. So mostly I wanted to, through this is one, show it's very simple math, but it's kind of death by 1,000 cuts. There's a lot of different components to each one to add up and track. And when you have 50, 60, 70 or more, this can get pretty complicated to calculate week over week as we go through the program. Any questions on that math? I just want to give you an idea of what the poor people who manage these programs go through when you're being asked to get all the A1Cs less than 9 in clinical practice. Realize that there's people like myself doing this kind of math behind the scenes to report on how we do, and have pity on them for what they have to do each year. Now, one thing that happens that's interesting is that CMS, which is Medicare, has actually figured out that it's good to reuse measures. And so when you look at particular ones, we've talked about diabetes care, and you notice I've talked about blood pressure and depression and smoking, colorectal cancer screening. These are actually overused by CMS. They're put into multiple programs. And so diabetes care is in a variety of programs. So if we get good at diabetes care, it not only helps in my QIP or prime programs, but also in FQHC reporting. It helps in MACRA and MIPS for individual providers. And so we find that there are certain hot topics that continue to come back to us in quality programs. And the thing to look at here is that none of this is bad medicine. Diabetics, keeping their A1Cs low, blood pressure, keeping it down, screening them for depression, intervening and getting them less depressed later. It's called remission or reduction. Seeing if they're smoking. Even just doing something simple like, do we reconcile their med rec when they come out of the hospital? Do we reconcile it as they leave? And do we reconcile it with the patient when they arrive for their first clinic visit post-discharge? Something as simple as that, we have found phenomenally reduces medication errors just because we checked as they went out and we checked when they were seen again in ambulatory. And these things really do help improve the quality of our patient experience, which is why CMS uses them in so many places. Just in this happens to be my own personal cross-reference. We have it here at UCI. There's a whole bunch of programs right now that we're tracking, and there's 120 different measures, but they are actually used 220 times in different programs. Some are inpatient hospital, some are ambulatory, some are provider-based, and some are contract-based. So we're seeing the full span of different types of quality programs and the same measures repeated again and again within them. It's why when you're out in clinical practice, you're going to hear people focusing on these things all the time because they carry so much either qualifying or financial impact for the organization, much less good patient impact as well. So why do they do that? It increases the attention by putting more money and more programs behind it. People really do focus on it, and it really does work. It really inspires people to improve what we do in clinical practice and make sure we do improve patient outcomes and get really good at delivering care, because not only is it good for the patient, but it's good for our organization as well. It's a great way to make sure that additional funds and attention is allocated towards improvement. So again, as you're going out into clinical practice, one of the things when you're trying to talk to leadership, be it the medical director for the department you work in, be it the CFO, chief medical officer, you're saying we need more of whatever it is, X, Y, or Z. Having quality programs behind it actually helps, in a sense, authorize or make it a wise funding choice to improve care. Some cases in point, we just have now started point of care, what are called INR systems. This is a lab test used for people who are on Coumadin, a blood thinner therapy. Point of care machines where they can do that right in clinic and not have to have them go to the lab. We've also been putting out machines that can do A1Cs. Right there, we're getting some cameras that can take the images necessary for the eye exams that we were talking about earlier, so that we can drive. It turns out that in diabetics, getting annual eye exams is actually quite challenging. So we're buying very expensive cameras that can integrate right into the medical record, take photos of the eyes that can be read by the appropriate clinicians, and we're making sure we get better at doing eye exams on diabetics. Now, that's really good clinical practice, and you could say that we should have been, we should be doing that already, but it's the presence of these quality programs that with the funds that you can earn by doing it well, that really provides kind of a kick in the backside sometimes to say, no, let's really get thoughtful. Even if we have to invest, it's a wise investment, because year after year, we'll just get better and better at it, and we'll earn these funds every year. So it really does help. And so when you're dealing with management, it's really good to bring this forward and say, look, we can make this in quality programs if you invest in staffing or equipment or different functionality. And more than anything else, the reason CMS, commercial programs, the state continue to use these same metrics is that they are very interested in serving these populations, because typically they identify a huge portion of the spending that the federal government and the state government is putting forward. Diabetics, hypertensive, end-stage renal disease. These are patient groups that consume tremendously high percentages of our healthcare dollar. And so they want to make sure that we're doing the absolute best we can to do that. So in a sense, the quality programs really do push us towards better care for the groups that consume a lot of care. And I think that's actually a good, if there's any place where we put our dollars on that, that's probably one of the better ones to do. Okay, we are coming up on time, I believe. I would just ask if are there any questions or anything I can clarify or provide for you guys?
I haven't seen any questions come through, but I personally just want to know your thoughts, Scott, around who is brought into the room when having these discussions. Some of the qualms that providers might have when they are meant to meet certain quality measures or when they are meant to adhere to certain quality standards, et cetera, is this idea that it may not always align with what they might be doing in practice, right?
Mm-hmm.
So I wonder who is actually in the room when decisions are made, because you told us what components or what pieces are considered in making these and developing these quality measures, but not necessarily who.
Yes. So it varies at each place, and I'm very, very proud of what we're doing here at UCI. So I will show my love for the facility that we're in, because when we look at quality metric programs, we start with clinical people. We go right to the medical directors, and we have certain champions here who we start with the clinical side of the metrics. We say, which of these metrics can we put towards a higher standard of care that we wish to provide here? I've learned myself not to lead with, we're going to do really good at QIP, we're going to do really good at Prime, because clinically, honestly, who cares? What really drives people is there's a standard of care that we believe we should provide. So it has to start with clinical. And almost every time the clinical people say they want to go higher than the metric. If you saw the diabetic one, and they were topping out at like 75% nationally, our goal here at UCI is 100%. We want every single diabetic under 9. We're not happy until they are. I love that. We set an insanely high standard that no one else can reach, and we just continue to work for it because it's good patient care. But that takes clinical involvement. So it's medical directors, champions from different departments, be it from cardiology. They have a huge input from cardiology, pediatrics, all sitting at the table with me talking about what should we set as our internal goals. And what I tell them is, that's wonderful. Let's go after it clinically with a high standard of care. We'll ace the programs. And we have. We're extremely good in quality metric programs for that. I don't know if that answers your question.
It does.
I will say also, we go collaboratively to leadership to say, we think you should invest $1 million because we're going to make 5. We go together as a clinical group with usually IT support and leadership, like our ambulatory leaders. We'll go to finance and say, we want this money because we're going to do this, and this is how we're going to earn it to pay for it. It's been a very effective strategy, and it's wonderful here at UCI. It's extremely collaborative. Yes, in terms of patient experiences, we do poll patients. We were using one vendor. We just switched to another one. I think it's called NRC. But every patient who's discharged from the hospital or from a clinic, a certain percentage of them get questionnaires, either through MyChart, either through an online poll or in paper. That's all collected by an outside agency and fed back to leadership. And we measured that for 5 years. That said, would you refer this provider had to be above a certain rate. And we earned a fair amount of money in quality programs because our rates were high. So yes, we do. And it's actually been very effective at it too. And okay, so I think they're asking for post-lecture feedback. And if there's no other questions, I think we are 4 minutes to go. Anything else?
I'm not seeing anything else. So I do want to thank you, Scott, for being with us. You give us a really necessary breakdown of what this looks like and what all of it entails. So next time someone says we're trying to deliver quality healthcare, you can think back to that lecture with Scott Thompson where he made sure that you understood what that meant. We're going to keep with the quality theme today. And our next talk will be starting in just a few minutes. So thanks for being with us, Scott.
Okay, thank you all.